To the webcast today from KKCTH. This webcast will be carried out by, the program will be conducted by Dr. Ram Kumar, pediatric dermatologist of our hospital. Actually, since it's a dermatology discussion, we don't have all the cases. We don't have a single case discussion. Today we have an assortment of several images in dermatology, and each one of them will be discussed by Dr. Ram Kumar in like an OSCE discussion. Over to Dr. Ram Kumar.
Thank you, Dr. SDS. Today I will be discussing about dozen OSCE pattern dozen cases. Each of them are very much related to skin and systemic medicine. Some of them are only skin related conditions, but all of them are very useful in your practice and for exams also. This is the first question. This is a 13-year-old girl who had presented to us with this multiple painless skin lesions, which are gradually increasing in number for the past 4 or 5 years. Just look at it carefully, look at these lesions. They are almost of uniform size. Most of them are around 1 centimeter size, etc. like that. Okay. Now, so can you name this condition? It's a spotter. It's an adolescent girl. Can you name this condition? Yes, correct. This is adenoma sebaceum. So, it's pretty easy. What is the cause for this adenoma sebaceum?
It is due to the abnormal growth of the blood vessels.
Yeah. Adenoma sebaceum is actually it's a misnomer. It is not. It has got nothing to do with the sebaceous gland. So it is just like another hamartoma. Why do you get so? Having said it is adenoma sebaceum, which condition do you see commonly adenoma sebaceum?
Sclerosis.
Any other condition do you know where you see adenoma sebaceum? Okay, go and find out what other condition in which you will see adenoma sebaceum also. You will also see in multiple endocrine neoplasia, MN, type 1. Adenoma sebaceum. Okay, so this adenoma sebaceum is a misnomer, and having said that, it is the most common condition where adenoma sebaceum occurs is tuberous sclerosis. So, what is the basic pathway defect in tuberous sclerosis? So, yeah. What is the pathway? Which drug is now used for tuberous sclerosis? Which drug is used for tuberous sclerosis? That works excellently in this condition. And right now we have got we even formulate an ointment also. The topical formulation also for this.
Rifabutin?
No. mTAR, mammalian target of rapamycin. That pathway is activated in this tuberin hamartin. Normally they suppress that pathway. Mammalian target of rapamycin pathway. It's all the growth factors or the cytokines, they all work through this pathway. That's the final downstream pathway for all these various factors, growth factors, cytokines, and this pathway is constitutively activated because of this lack of suppressor proteins like tuberin and hamartin. So excess activation of this mTOR pathway is the cause for all the manifestations of tuberous sclerosis. That is why we use that rapamycin, sirolimus. Okay, and we even topically make a formulation of rapamycin and use this for this. That has given some good results in this condition. Okay, so we have discussed about the diagnosis and the skin lesion. Now, what are the other cutaneous manifestations?
Chagrin patch, ash leaf nodule, and
macule, ash leaf macule.
Ash leaf macule, and Cephalo spots.
But is it specific to this condition? Cephalo spot. Forehead plaque, cephalic fibrous plaque, shagreen patch, this ash leaf macule. So having said about ash leaf macule, when will you give significance to ash leaf macule? Suppose there is a one hypomelanotic macule, will you straight away take it as one, as a feature of tuberous sclerosis?
Two or more.
No.
Over the spine.
No, it has got nothing to do with this.
3 in number.
3 in number, correct. 3 or more than 3 in number. More than 3 in number is the correct answer. So now, what are all the major features of this? Because these two we can club together. What are the major features, diagnostic criteria for this? You know that recently there has been a change in the diagnostic criteria also, but major features remain the same.
Tubers in seen subependymal giant astrocytoma.
It's called SEGA.
SEGA and tubers. Second, third one is rhabdomyolioma.
Migration tract, tubers and migration tract. Then
And
rhabdomyoma of
heart.
Because that is the thing. In infant, when an infant comes to you, whenever you see the earliest feature of, suppose you see 3 or 4 macules, the first thing that I do here is take to our pediatric cardiologist and okay. That is one thing that you have to look for. So these are all seen in very early stage, and later on your this one renal angiomyolipoma, this chagrin, this angiofibroma comes only in an adolescent girl. Okay, even this this SEGA, subependymal giant cell astrocytoma, is also seen only in the childhood stage. All major features. Any minor features you know that? Because sometimes if one major feature and 2 minor feature also you can make a diagnosis. Any minor feature? Any other department that we have not discussed, specialty? Dental pitting. So dental pitting is one of the minor feature. Renal cyst is only a minor feature. Renal cyst is not a major feature. Okay. Shall I go to the next clinical scenario?
Antenatally, how you can diagnose is a frequent question by detection of the rhabdomyoma, or sometime you may pick up the cyst also. These two clues may give rise to a diagnosis of tuberous sclerosis antenatally for counseling.
Alright. Shall we go to the next one? It's again a 9-year-old child. Just carefully look into the rash. Proximal muscle weakness, but don't go only by this finding. Look at this rash. Very classical rash. Now,
Dermatomyositis.
good. Why do you say so? What is the name of this rash?
Heliotrope rash.
Very good. Why do you say so? So I am telling that it is only in SLE patient. It's a malar rash.
Which is also
Nasal, that means it is seborrheic dermatitis. If it is involving nasolabial, but it is seborrheic dermatitis. It's a very common disease. Why go for all this big funda and all?
here bridge is also involved.
Eyelids, yes. Eyelids is involved. That is why it is called heliotrope. Sun loving. Okay. Very classical rash. So now, just tell me about 2 extracutaneous features. Calcinosis, we cannot say it, I will not take it as an extracutaneous feature. Calcinosis, first of all, is a sign of poor response to therapy.
Muscle weakness, myopathy.
Myopathy. It is already there, muscle weakness, possible muscle weakness, and rash I had already shown you. These 2 are there.
Elevated CPK.
CPK. What are the other muscle enzymes you look for in dermatomyositis?
SGOT, SGPT.
SGPT you look for?
SGOT.
So what are all the other enzymes? Muscle enzymes generally means, what are all the other muscle enzymes? Tell me.
LDH.
LDH.
Aldolase.
Someone said aldolase. Aldolase, LDH, SGOT, and then CPK. These are the 4 muscle enzymes. Ideally you are supposed to measure all. What else? There is no answer from the what else? Muscle, what is there before muscle? No, yeah. Electromyography. Electromyography, you will get that picture, no? Electromyography, findings of myopathy, then muscle biopsy, then the skin lesion, heliotrope, the skin lesions, then enzymes and proximal muscle weakness. These are 5. At least for branding it as a definite case of dermatomyositis, there should be 4 criteria. If only 3 criteria are present, we can take it as a probable dermatomyositis. So you should be very clear about all this. So just mention 2 drugs which are useful to treat this disease.
Steroids and methotrexate.
Very good. Steroids and methotrexate. Sir, you want to ask any question? Okay. What about any different diagnosis for this rash? Vasculitic rash, does it look like this? Vasculitis, first of all, do you get on lesion on the face? You see lesions only on the dependent areas.
SLE.
SLE, okay. How do you differentiate SLE and dermatomyositis rash?
Involvement of eyelids.
Okay. Anything there in the hands?
Goiter and papules.
Okay. Goiter and papule. No, make it very specifically.
Multis.
Which portion of this hand is involved in SLE? Which portion is not involved in SLE?
Knuckles.
Yeah. Tell me.
Knuckles are involved in dermatomyositis.
Okay. And the phalanges portion is involved in SLE. Very good. Okay. So that is one differential diagnosis. Okay. I think we have discussed all these things. Shall I go to the next? It's a very common case you can see in your practice. Exam also. So I'll explain you what it is. These are all blisters. So vesicle means it is less than 0.5 centimeter. Bullae means more than 0.5 centimeters. So these are all studded over the entire buttock. This area is somewhat relatively spared. The convexity of the buttock. See, just peeling of the skin. Just we touched that area. It has got separated just like that. And lesions, multiple dense aggregated lesions on the buttock, thigh, legs. There is no erythema also. So whenever you look at this vesicular lesions, what is the first thing that you look for? So, no, I am not asking about the oral cavity, I am asking about examination of the vesicles itself. You will not straight away go to Nicholson. Before that, will you not look for the arrangement of the lesions? Whether it is grouped, whether it is dermatomal, whether it is there a particular pattern of arrangement? Simple thing is morphology, arrangement and distribution. This MAD, you remember this. Morphology, arrangement and distribution. Even if you forget everything, you will remember this. Morphology, arrangement and distribution. Where and all it is there. How it is arranged, what is it? These 3 basics, enough, we can diagnose any dermatology disease. So here, you don't see a particular distribution at all, because it is here also, it is there also, it is bilateral. It is not strictly unilateral, it is not strictly dermatomal, it is bilateral, and you cannot say a particular pattern of distribution. It is diffusely distributed over the entire buttock and lower extremity. And if you look at the lesions, there is no redness at all. It's a very clean, there is clear fluid. So it is a vesicle, it is not a pustule. Clear fluid, there is no redness and all. Did you notice crust anywhere? No crusting. And as you rightly said, this peeling of the skin with tangential pressure is called Nikolsky sign. Just it shows that there is a cleavage. Okay. Which is the commonest condition where you will get this. Okay. Staphylococcal. But can this child be, because I have specifically shown you only the button. Staphylococcal scalded syndrome is a generalized disease. That only indicates that there is some factor working on the bloodstream which is causing the generalized. So this is a localized disease. Tell me any disease which can be a precursor of staphylococcal scalded skin syndrome. Mike, please.
Bullous sympathico.
Very good. So this is bullous sympathico. Very good. So why do you say it is not impetigo contagiosa? That is the commonest impetigo. We call it as non-bullous impetigo. How often do you see bullous impetigo in your routine practice? Almost day in out you see in pediatric practice or dermatology practice you will see impetigo contagiosa. Bullous impetigo is not that commonly seen. That is why I have shown an infant. So why do you say it is not impetigo contagiosa?
Yellowish crusting is.
Yeah, crusting. Honey colored crusting. Golden yellow or honey colored crusting. So that crusting is not there seen, and in fair children you can notice some redness in impetigo contagiosa, whereas this is not seen here because it is mainly due to a toxin. So it is almost like a chemical type of separation of skin due to toxin damage, where there is less of inflammation, more of direct toxic damage. So it is more, the inflammation is not visibly seen in here. So differential diagnosis you can, other condition, what are the other conditions you can, all the conditions with blisters, vesiculobullous eruption you can list. Tell me two conditions with vesiculobullous eruption. Favorite, epidermolysis bullosa, anything else? Herpes, you should say herpes. Epidermolysis bullosa is a chronic condition. You don't lose anything by missing it, herpes. And then anything else? What is the common disease epidemic going on everywhere now? Hand, foot, mouth disease. Okay. Where do you see the skin lesions in hand, foot, mouth disease?
On the palm soles.
Ah.
And also in the buttocks.
Buttocks. Where else? Someone said it's not perioral. Oral itself. Something, any other place? Knee. So wherever there is mechanical friction like elbow, knee, buttocks. Buttocks is a very common site for, when this genitocrural fold is a very common site for hand, foot, mouth disease. Elbow, axilla, and in the abdomen. Okay, just above the diaper area, that margin, the fringe of that, you will see a lot of lesions of hand, foot, mouth disease. Okay, what is the cause for hand, foot, mouth disease? Coxsackie virus. Which is the commonest type? Good. Okay. So, in this condition, what is the organism causing bullous impetigo? What staph? Staph epidermidis? Staphylococcus aureus. Okay. What is the cause of impetigo contagiosa? I know you will jump into it. Which is both can cause. Okay, which is the commonest cause of impetigo contagiosa? No, not at all. Staphylococcus is the commonest cause of impetigo contagiosa. Staphylococcus mixed with streptococcus is the second common. Very rarely streptococcus alone is capable of causing impetigo contagiosa. Please note it. So Staphylococcus is the commonest cause. Staphylococcus aureus mixed with streptococcus. Second common. Least common cause is streptococcus. Otherwise you will end up prescribing ampicillin in your practice. That never works in impetigo contagiosa. Okay. So bullous, in contrast to that, in bullous impetigo is always caused by Staphylococcus aureus. Is there any symptoms? Any systemic symptoms of bullous impetigo? Water. Any systemic symptoms of bullous impetigo? Come on, you should come out with the answer. Fever, anything else? Any systemic organ? Can a child with bullous impetigo get admitted for some other reason? Glomerulonephritis for streptococcus. I think glomerulonephritis for streptococcus, streptococcal impetigo. That is, I told you, impetigo contagiosa can be rarely caused by streptococcus alone. So in that cases you may get, if it is infected by nephrogenic type, you may get glomerulonephritis. What about staphylococcus? That is the purpose of putting this slide. Pneumonia, very good. Then what else? Pneumonia, what else? Diarrhea, GI manifestations. So these are all the complications of bullous impetigo. So children with bullous impetigo, in infant particularly, if the complications are present, then you should give an systemic intravenous or antibiotics. Okay. So what is the drug of therapy? Clindamycin. So the first drug for staphylococcus is clindamycin. Cloxacillin. Good. So suppose you are given a choice, cloxacillin and vancomycin. Which drug will you choose for a methicillin sensitive staphylococcus aureus? Good. Why? Why not vancomycin? Why not vancomycin? Some people prescribe vancomycin directly for methicillin sensitive staphylococcus aureus. Mic kudunga. Someone gave an answer. Why not vancomycin for every staphylococcus infection, whether it is methicillin sensitive or not sensitive? Have a lively discussion.
The resistance may
resistance. So only for convenience you are using vancomycin. Suppose there is no problem, money is not an issue. So vancomycin is nephrotoxic. Yeah, because vancomycin acts slowly. For MSSA, cloxacillin or other drugs are the drug of choice. Vancomycin is not the first drug of choice for methicillin sensitive staphylococcus aureus because it works slower. It works slower, that is the reason. The cloxacillin is faster, cefalexin is faster, vancomycin is slower. So it should not be the first drug of choice for methicillin sensitive staphylococcus aureus. Okay. Shall we go to the next one? So, can you notice this? Behçet disease. So, yeah, Behçet disease. Conjunctivitis, oligoarthritis. So, Behçet disease, you will get conjunctivitis. What is the characteristic eye lesion in Behçet disease? You may get conjunctivitis also. What is the characteristic eye lesion? Hypopyon uveitis. So, if anybody comes with shows genitalia to you, you will look for the eye and diagnose it. Behçet disease. What is the major criteria for Behçet disease? What is the major, which is the most important criteria for Behçet disease? Yeah, oral ulcers, how many episodes per year? Even hand-foot mouth disease also, patient will come to you with abscess ulcer. Typically it will look like abscess ulcer. With erythema, it will take around a week or so to clear. So, please use your mic.
3 or more episodes.
3 or more episodes per year. Okay. Then what are the other features you look for in Behçet disease? Arthritis, genital aphthe, oral aphthe, genital aphthe, and then skin lesions like acne like skin lesions, erythema nodosum, eye involvement. Okay. So, but do you think that this is measured disease? Just look at it following bloody stools.
Sir, reactive retest disease.
Yeah. So what is a classical lesion here? Can you look at the margin? It's a very rare photograph. You just look at this. This is called succinate balanitis. It's called succinate balanitis. So urethritis, conjunctivitis, oligoarthritis and balanitis all. So I have already discussed to you all those extracutaneous features and differential diagnosis. So in this case Shigella was the organism. This boy had a Shigella dysentery. So any other doubts in this? Okay. So we are running short of time. We'll go to the next one. Once again, a common case in exam or in practice. Yes.
Fixed drug eruption.
Why do you say it is fixed drug eruption? Any reason for that? Can you describe this lesion? Can you describe this lesion?
It is a hyperpigmented macular lesion with well-defined margin.
Yeah. The starting stages you will be able to see an erythema, but now it has faded. Okay, why do you say it is, my question is, why do you say it is a fixed drug eruption? Why not simply say drug eruption?
Recurrence at same site.
Yes, okay. Recurrence at the same site. Do you know the reason for that? Okay, it's okay. Recurrence at the same site. Just tell me about any one or two common drugs that will give rise to this reaction that you see routine. Someone said carbamazepine. Vague guess. Sulfonamides. NSAID. Then? Louder please. So, sulfonamide, NSAID, including paracetamol, NSAID.
Penicillin. Any aminopenicillin or
Penicillin.
beta-lactam antibiotic.
Tetracycline. Of course, more than 8 years use in children. So, as far as this anti-epileptics, only barbiturates can cause this fixed drug eruption. So, how soon do you get this eruption after taking the tablet? Because I have written a few hours. So, yeah, within half an hour to 8 hours. Just within 13 minutes you can get this rash. Okay. So, this, apart from fixed drug eruptions, can you name any 2 or 3 adverse cutaneous drug reactions?
Stevens-Johnson syndrome.
Good.
Dress
Dress means what? Dress means?
drug reaction to
Drug reaction, eosinophilia, systemic symptoms.
Yes, eosinophilia and systemic symptoms. Okay, have you said dress? How often do you see eosinophilia in dress?
It's not compulsory, but usually it can
Only
be seen.
30%, very good. So, dress, Stevens-Johnson syndrome, urticaria,
More than Stevens-Johnson syndrome, it's urticaria.
exanthematous eruption.
Any drug can produce urticaria.
Exanthematous eruption. The most common adverse drug reaction is exanthematous eruption.
Yeah. Other thing is a morbilliform eruption.
Exanthematous,
But the
you have got
commonest benign drug eruption is a morbilliform. That means morbilliform means measles-like. It's a macular lesion or sometimes even a maculopapular lesion coming after penicillin or amoxicillin. But it is not a dangerous reaction and you can even continue the drug if it is only am I right, Dr. Ramkumar?
Yes, sir.
The morbilliform eruption is there. It's not a contraindication if the drug is essential for any child. It's one of the most benign skin lesions is morbilliform eruption. The other thing is, the peculiar thing in fixed drug eruption is that it comes in the same time every time you give the drug. For example, if it comes in the cheek, next time the drug is given, it will come exactly in the cheek. That is what the parents say, it comes in the same site, same site and after the same drug, it is nothing but fixed drug eruption.
Codeine also can cause this fixed drug eruption. Okay. So any systemic disorder, I am sure all of you can answer this question. Dr. SPS has already gave a hint to you. Any systemic disorder predisposing to adverse.
Somebody with a particular systemic disease is more prone to develop
Human immunodeficiency virus infection. See, ADARs are very common in HIV. Second thing is infectious mononucleosis in an adolescent. Oh yes. Okay. Just to give you some example.
the so-called ampicillin rash is supposed to occur in about 80% of patients who have infectious mononucleosis. Which is a diagnostic clue. You give ampicillin, child develops rash when there is fever, morbilliform eruption, diagnosis is EBV infection.
Okay, we will go to the, any doubts in this? Shall we go to the next one? It's very pretty easy it is. Just look at this rash. I told you should look for morphology, arrangement and distribution. Of course, there is no question of distribution here. It is very clear, forehead and the vulva. Look at this rash.
Psoriasis.
Why do you say so? I say it is Pitrius alba. Leave alone that vulval lesion. Suppose I am projecting only this face one. I say it is Pitrius alba.
Scaling, the silvery
Scale. Can you be more specific? Do you have fine scaling or thick scaling?
thick scaling.
Thick scaling. Thick scaling. And what else? Scaling is not the main feature by which you differentiate a Pitrius alba or a dermatitis from psoriasis. What else do you look for? This one. Yes.
There is no
Sharply marginated, well defined margin. Thick scales. And suppose you rub the scales, you will get fine bleeding point. That only indicates that the blood vessels are proliferated in the dermis. So this is classical psoriatic plaque.
gut data.
Okay, less common than an eczema, but still you see this very clearly seen in this area. So what are the differential diagnosis? I've already narrated.
Tinea.
In between the scales there will be erythema which won't be usually seen in Pitrius alba.
Yes. Yeah. Any other differential diagnosis?
Tinea.
Yeah. How do you differentiate tinea from this?
Central clearing.
Central marginal scaling. Okay. Okay. And irregular margin. That is classically you can see. That is because organisms, it's irregular margin. And
Family history maybe.
family history. You mean to say every patient with psoriasis
Some
should have a
patients-
family? No. Never may commit that mistake.
Okay, sir.
No question of that. Okay. So it's a clinical diagnosis, not by morphology, not based upon any particular history. Psoriasis you should diagnose based upon the morphology. You should not ask for any other history and all. Okay, except the fact that it is persisting for some more than a few days. And any mode, two modes of therapy.
PUA. The PUV.
Is that the first line of therapy? As if it's the first line therapy you have been saying.
Zoral.
Directly oral methotrexate. Topical and systemic. Why not you make a small classification? Straight away go for methotrexate or anything. Topical and systemic. Topical. Isotretinoin is not available as a only one preparation is a topical gel. I think you mean retinoic acid cream. No, not at all. Not at all. Tazorotene is used.
Systemic retinoids may be used in very severe disease, but
severe.
topical retinoids are not.
Tazorotene that will give a lot of irritation in this area if you apply. That is one of the modes of therapy, tazorotene. That's So topical steroids, calcipotriol,
Coal tar.
anthralin, salicylic acid also you can. So systemic, there are four modes of therapy. One is phototherapy. one is methotrexate, one is cyclosporin, the last one is, acitretin, not isotretinoin.
What about topical vitamin D?
Calcipotriol, we mentioned it, sir. So calcipotriol, topical steroids, coal tar, anthralin, systemically, phototherapy, methotrexate, cyclosporin and acitretin. Isotretinoin is very rarely used for psoriasis. Isotretinoin is used for acne. Okay, shall we go to the next one? Sir, are we running short of time? So comorbidity.
Arthritis.
Yes. Arthritis. Anything else? Loss of nail is not a comorbidity. And you don't lose your nails in psoriasis. I think you have mixed up lichen planus with psoriasis. Lichen planus, there is a damage to the nail bed. That is not a thing in psoriasis. So any systemic comorbidity, metabolic syndrome, that is rare in children, but we do see. Increasingly we see more and more patients with abnormal lipid levels, and then obesity, insulin resistance. These are all more we see very commonly in moderate to severe type of psoriasis, not a child with mild psoriasis, moderate to severe type of psoriasis. Okay. Now I think you can all will make up this diagnosis. Yeah. Tell me any two complications.
Secondary staph infection.
Secondary infection.
And
yeah.
glomerulonephritis.
Okay. Anything else? Eczematization is also one of the complications of scabies. So you should, whenever eczema in this non-classical sites, you should also look for scabies. Okay. So name two therapeutic agents used in this condition. I am sure all of you have the answer for this. Permethrin, how many percentage?
Topical permethrin
5%, very good.
And oral ivermectin.
1%? Linden. So what age do you use Linden, what age do you use permethrin? Because I want to make it clear. So you use Linden in a gamma benzene in a 6 months old child. Then 2 years. More than 2 years. 1% gamma benzene hexachloride more than 2 years. That's a neurotoxic one. Okay. So someone mentioned about ivermectin. Tell me what is the dosage of ivermectin? What is the dosage of ivermectin and any contraindications for giving ivermectin? Do you give ivermectin in any infant or a 3-year-old child or 4-year-old child or 8-year-old child? Irrespective of the age, do you give oral ivermectin? So ivermectin should not be given in children less than 15 kg of age, less than 5 years of age and less than 15 kg. Should not be given because it works on the CNS system, the glutamate channels of the mite. So that it's a lipophilic drug. So it will easily cross the blood-brain barrier and produce lot of adverse effects. It should not be given less than 5 years. And the dosage is 200 microgram per kg. So 200, it's available as 3 milligram, 6 milligram, 12 milligram strength. Dosage is 200 micro. So it's a very important thing that you should know. Okay, ivermectin. And any bedside test for diagnosis. Yeah. Do you often see the organism in scraping? Why? It's not like malaria that you run behind the patient at midnight, wake them up. So that is because only some 10 to 12 mites are seen in average in a person. So the most likely when you scrape a side, you end up with a negative result.
In children, 12.5% in infants. Again,
12.5.
not used because it is irritant and stinging, and these are the preparations. The other thing is, olden day there used to be a soap called tetraethyl thiouram monosulfide, tetnosol soap. It's no more there. It's a useless, weak scabicide rather, scabicidal agent. Tetraethyl thiouram monosulfide is no more available. These are some of the agents. Now only your permethrin is the drug of choice. Again, gamma benzene hexachloride because of neurotoxicity, and again irritating in nature. So, and last thing is, if there is an active infection, you should treat infection before you put any topical antiscabitic preparation. If there is severe pyoderma in an older child with scabies, better to treat the infection and give ivermectin rather than apply topically. Then remember, there is one more drug which should not be given like ivermectin below 15 kg, that is mefloquine. Very similar, again neuropsychiatric reaction.
Yeah, if there are infant, if there are lesions on the face, you can use topical permethrin. See, from your point of view, you should know what are all the characteristic sites that are involved. It will come like a circle. That you should know. Second one, in infant, how does the distribution differ in infant compared to the older children? These two should go home and find out these two. Yeah. And what are the morphology also? Pustules will be there in the palms in infant. Okay? Due to, we are running short of time, we go to the next one. Again, all the nails are involved. Someone said psoriasis. Yeah, psoriasis is also an answer. You can, but can you explain these findings? So what you see is a roughness and longitudinal ridges. Pitting is also there. This is called as trachonikia. So this is the characteristic features of what is called 20 nail dystrophy. All the nails are involved in this child. So when you follow up these children, some of them very few of them, it is either in overwhelming majority, 80% of them, it subsides without any residue. Some 5-10% of them may end up with psoriasis or alopecia areata. So, but majority in the recent studies show majority, it's a benign condition in the majority of the children. Okay. So, I already told you psoriasis is one of the differential diagnoses. So, just tell me any two disorders where you look for nail involvement or any systemic disease with nail. Okay, iron deficiency, Almia. What are the changes that you will see in that?
Koilonychia.
Koilonychia. Anything else?
And dyskeratosis congenita.
Dyskeratosis congenita. Very good. Dyskeratosis congenita. What else you will see in that?
Teeth, peck-shaped teeth.
Dyskeratosis, you will get only patches. White leukoplakic patches on the white and then neck and axilla, you see reticulated pigmentation, and then you look for hematological abnormalities. But there are so many other, you can say ectodermal dysplasia, so many other conditions, nail patella syndrome, heavy metal poisoning. What do you see in heavy metal poisoning? Ordinary Bu's lines, any systemic illness, just fever also you will see. Okay? So, diagnosis already written there. Any differential diagnosis? Differential diagnosis. It's very clear because anybody will diagnose it. So primary herpetic gingivostomatitis, you will get lymph node enlargement, painful ulcers, drooling of saliva, anterior part of the face will be involved. So what are all the other conditions? Okay, any bedside test that by which you can make a diagnosis? Zank smear. So what do you see in Zank smear? Alopecia areata. What else? Something else? Okay. So why do you say it is a carrion? Let us leave that. Why do you say it is a carrion? Carrion is, what is carrion? Carrion is an inflammatory form of tinea capitis. Children scalp is involved in dermatophytic infection. Adults, it is not involved. Adult scalp is not involved. In children, scalp is involved by dermatophytic infection. So, why do you say it is carrion?
Pain, because it's painful.
Pain. So, anything that is suppose a furuncle also will have pain will be there. The child won't allow you to touch that. So, every furuncle is a carrion, Indian word for carrion.
Some, this one, crusting is...
Crusting, wherever there is serum, there will be crusting. Eczema also you will get crusting. Burns also you will get crusting. Whenever crust is nothing but a dried up secretion. Boggy. So any boggy nodule is a carrion. Any nodule is a carrion. Because it is come on the scalp. But this is called MCQ syndrome. Google syndrome. You should tell me why did you diagnose it as carrion? So simple thing is, whenever you see such a nodule on the head of a child, so if you are able to pluck the hair out or it comes out very easily, if it is bald, then it is most likely that there is a disorder damaging the hair follicle. In that case, you can accept a diagnosis of carrion. In furunculosis, that hair will not come up easily, though it is also a folliculitis, deep folliculitis. Furunculosis is a deep folliculitis. There also you have a lot of inflammation, extreme pain will be there. But there the hair does not come out very easily. So when the hair comes out, it's a bald patch, hair comes out easily, it is called as carrion. And you told about alopecia areata. Alopecia areata, what you see is a smooth bald patch. No inflammation, nothing will be there. Just most of the time the bald patch will be noticed by the parents. Or someone else will notice and tell them that there is a bald patch. So that's a very smooth patch, just like a 50 paise coin or a 1 rupee coin, a smooth circular or oval, clean patch. There you will not see even a scale also in alopecia areata. So here is a boggy swelling with some pus also coming out. Lot of pus, follicular pus coming out of the follicle, extreme tenderness. There was cervical lymphadenopathy, hair loss, and we plucked the hair and we were able to find the arthrospores. So we were able to demonstrate the diagnosis. That is a useful bedside investigation. You can. So what is the investigation? How do you demonstrate the organism? Yeah, KOH preparation of the hair. So that's a useful bedside laboratory investigation by which you can arrive at a diagnosis, confirm the diagnosis. What is the drug of choice for carrion? Right. Drug of choice. Name 2 systemic antifungal drugs. Will topical cream work in this? Yes. Rhizophilin, what else? Ketoconazole. Ketoconazole is not available in the market anymore. It's not available. What are the newer azoles? Caspofungin. I don't have the guts to give caspofungin for such a small child. Caspofungin. Fluconazole. What else? Amphotericin. Again, I think you are talking about systemic mycosis. This is not a systemic mycosis, not an immunocompromised patient at all. It's a otherwise perfectly normal child walking into our OPD. So what else? Have anybody heard of terbinafine? Itraconazole. Itraconazole can be given in children. In fact, a formulation is available in abroad which can be given for children. But here we have only capsule. It's not with cyclodextrin combined formulation. It is available in abroad as a liquid form also. And in fact, in children it is a better drug because the drug interactions are very few in children compared to others. Because you don't see a lot of children on multiple drugs, whereas adults will be on a statin, will be on antihypertensives and then diabetics, sometimes even antidepressants and all psychiatric drugs also in children. So a lot of drug interactions will be there. So you have to know some of the drug interactions. So in this child, drug of choice is terbinafine. I think it's still terbinafine is not, Rhizophilin is still the drug of choice. Eosinophil is still the drug of choice. You should ask him to take after food. So what is the dosage you will give? More than 15 mg. 15 mg per kg is the usual dosage. Will you give the same dosage if the child is already on heptine or some anticonvulsant drug? Very rare involvement of.
Two or three important points. In a young infant, scabies will not produce pruritus. The baby will present with what? Incessant cry. He doesn't know how to scratch. 2. The lesions occur in the face more often in infants with scabies. Why? Why? Where does scabies come to the baby from? Mother. Usually the mother will have lesions in the axilla around the breast. The lesions are more around the face, which is very unusual in an older child. 3. Lesions are more extensive. So-called Norwegian scabies per se is supposed to occur in children who are institutionalized, immunodeficient and young.
Down syndrome.
Right? So, lesions can be more extensive. In general, complications are more in a younger child. Right? These are some differences in scabies in young infants. And again, eczematization is more common in younger children than older children. Right? Why does you showed that, can you go back to that slide on the staphylococcal thing? Why not?
Yeah.
1 minute. Why not this be staphylococcal skin scarlet syndrome? Huh?
Localized.
Why not this be staphylococcal skin
The characteristic feature will be there, Staphylococcus scarlet skin syndrome. You should tell us characteristic distribution.
I think if you look at it carefully, in this child, in the left leg, there is actually a boil you can see. If you see carefully, yeah.
It's a boil.
Remember, in a child with staphylococcal skin scarlet syndrome, very rarely you get an active skin disease.
Not like what is described in the books. In practice, very rarely you get a...
You don't usually find somebody who has a furuncle or a pyoderma simultaneously having staphylococcus.
Usually otitis media, eye infection are described in the books, but very rarely you see in practice. Okay.
And one other thing, bullous impetigo is all, non-bullous impetigo can be streptococcal or staphylococcus, but bullous impetigo is always staphylococcus.
Okay.
What are the indications for systemic antibiotic therapy in impetigo?
Discuss, sir.
Anybody? Huh? Why? No, why should you treat lesions around the mouth? The child will lick the ointment and make it inactive. That's the main reason. In addition to being in the dangerous area, around the mouth, the child will do like this. It won't be effective. Right? Any other indication? Systemic complications like lymphadenitis, fever, right? Abscess, cellulitis, extensive lesions, anything complicating.
Eyelid. Okay, we'll end up our presentation with this. It's an interesting case. Do you know what is this blastoid distribution? It's a peculiar line of distribution where you will see all the diseases. You will just see them almost generalized. It's a 22-day-old baby. Why is that the eosinophil count is 80%? Cutis marmorata telangiectasia congenita. You read it yesterday. Okay. You get eosinophilia in cutis marmorata telangiectasia. Where did you notice atrophy here? Any ulcer or atrophy? Anywhere any atrophy or ulceration or hypoplasia? Or you are seeing that... Yeah. Adam's Oliver, you will have macrocephaly and all that will be there. CMTC is not like this. It is, eosinophilia 80%. That gives the diagnosis. Because eosinophils are the major they are all the damage in eosinophilia, incontinentia pigmenta is done by the eosinophils. All the systemic manifestations are because of the eosinophils. You must remember that once the eosinophilia has gone, the first 3 or 6 months, all the damage has been already done. Incontinentia pigmenta. Very typical. I told this 80% should give you clue. You should not jump and say herpes simplex. Of course, you should do a Zhang smear. This child we did a biopsy and we found eosinophil collection in the skin. So this 80% eosinophilia is a very important. You can take a Zhang smear and you will find lot of eosinophils there.
There are 4 stages.
4 stages.
There are 4 stages. Can you tell us the 4 stages of incontinence?
So from newborn to the first 3 months, you will see these vesicles along this flash coil distribution. Subsequently, you will just get like wart-like lesion, hyperkeratotic lesions. And follow that after 6 months to 2 years period, you will get hyperpigmentation. This incontinentia pigmenta, the name is because of the hyperpigmentation. And if you examine the mother of the child, the mother may have atrophic lesions in the leg, loss of certain linear patches without sweating, without any hair or, no absence of sweating. That is a 4th stage, atrophic stage. So, vesiculobullous stage, 2nd stage is hyperkeratotic, 3rd stage is pigmentation, 4th stage is atrophy. There are 4 stages that will classically follow all. Every patient you may not be able to see all the 4 stages, but if you carefully look for, you will see that. So eosinophilia is there in the 1st stage, it vanishes during the 2nd stage. So what are the internal organs involved? CNS, very important. Anything else very important? Yes, ophthalmic involvement, CNS involvement, dental. Okay. So we will end up our presentations.
Any questions from the students? Okay. Thank you, Dr. Ram Kumar, for the. Please give him a big hand for the. Thank you.
ஊட்டியாச்சு கொஞ்சம் எடுத்து pus also coming out, lot of pus, follicular, pus coming out of the follicle, extreme.
Tuft of hair and sacral dimpling can be present since birth.
Pus
Tuft of hair and sacral dimpling can be tuft of hair and sacral dimpling can be present since birth.
Any capsulitis spark is a neurocutaneous marker?
No.
More than 6 in number, and its size depends on the age group. So pre-pubertal age more than 5 millimeter, and post-pubertal it's 115 millimeter.
Yeah. Okay. What else you see in neurofibroma?
Tuft of hair and sacral dimpling can be present since birth.
Any capsulitis spark is a neurocutaneous marker?
No.
More than 6 in number, and its size depends on the age group. So pre-pubertal age more than 5 millimeter, and post-pubertal it's 115 millimeter.
Yeah. Okay. What else you see in neurofibromatosis? Can you directly establish the diagnosis if you see 6 K-phenolate spots?
No, sir. Actually, like for type 1 and type 2, it's there. So
I am talking about one recognition, type 1 only.
Type 1, we have to have K-phenolate spots more than 6 in number and the size depending on the age group. And then osseous lesions, that is skeletal lesions should be there, either a sphenoid dysplasia or scoliosis, like that should be there. And neurofibroma should be there. And if it's a plexiform neurofibroma, 1 is enough, or a neurofibroma, 2 or more neurofibroma is needed. And then history of neurofibromatosis, 1 in a sibling or a family member, relative.
No, instead of telling like this, can you list what are the things that you look for? When you see a child, suppose assuming that the child has got 6 neurofibroma. Say for example, let us take that a 2.5-year-old child has presented to your OPD with 6 neurofibroma as per the, satisfying the criteria that was proposed, like 0.5 centimeter, more than 6. So will you straight away take it as stamp it as a patient of neurofibroma, or what are the things that you look for?
So other, like in eye examination, we should look for lesion nodules, but that can be made out usually by a slit lamp examination.